If you look at a graph of the GDP per capita against life expectancy, you see more variations within the bands of life expectancy often than you see variations across GDP levels. Now, obviously, up to about $10,000 GDP per capita, life expectancy increases very dramatically. You absolutely do need a certain amount of money in your country to deliver basic healthcare. But after that, the variations are about policy choices. So income is not destiny. And so countries that are able to develop systems, whoever is providing it, which reaches all of their people, that are able to provide most of the services that people need in an affordable way, thinking about what sort of cater to use, are able to work across sectors on what we would call the social determinants to support health, and where people are engaged in healthcare, trust healthcare, have input into decision making, do better.
Welcome to Analyzing Healthcare podcast, brought to you by Scale Community. Scale Community is a global healthcare-focused member network where healthcare leaders come to connect, learn, share ideas, and shape what's next in our evolving healthcare landscape. To take advantage of all that Scale Community has to offer, from expansive content to virtual and in-person events, to interactive peer networking opportunities, and more, check out Scale Community at www.scale-community.com. Membership options range from free to paid, so if you enjoyed today's discussion, please take a moment to sign up for your preferred membership level.
All right, welcome to this edition of Analyzing Healthcare, our Scale Community podcast. We are very grateful to be joined by Dr. Kumanan Rasanathan. I'm going to call you Kumanan. Welcome this morning. It's a pleasure to have you.
Good morning, Roy. It's a pleasure to be here.
All right, so I met you, Kumanan, in Berlin at the World Health Summit, where you seemed to be running the show. Literally. I think there were several thousand people there, all of who knew you intimately. Why is that? Talk to us about your relationship to the World Health Summit and also your history at the WHO, which, to my knowledge, you've been there for quite some time, leading many global initiatives, doing amazing work. And for our audience, this is a rare opportunity to actually speak to the WHO, to understand it and get more intimate with it, as opposed to reading about the WHO indirectly, secondhand through journalists, and therefore having to sort of accept a journalist viewpoint. So let's hear it from the horse's mouth. What's it been like working there? How does it compare to other institutions, global institutions like the OECD, the World Bank? How does it fit in with the UN? Teach us.
Well, it was nice to meet you at the World Health Summit in Berlin. As you say, that event now brings together 4,000 plus people in global health who are trying to improve the world's health. And I am fortunate because I have been working in global health now for about 20 years, I think, or even more. And I do know many of those people. And it's a wonderful community. I mean, it's this idea that people from different countries can come together around global and national challenges, that we can learn from each other, that we can share our knowledge, we share values. And it's an idea that unfortunately is a little bit under attack at the moment, right? It's not the easiest times for global solidarity. But my own experience with the World Health Organization, which I started working for WHO in 2007, and I've been very fortunate with my career. I didn't plan to join the World Health Organization, something that, like many things in life, that happened slightly accidentally.
This
I
wasn't
mean,
even
I
an
was
age.
working at China at the time, and I was offered a job at the World Health Organization. I'd actually planned, after working in China, to go and work in Ecuador. And I took an opportunity, which in the beginning, my initial contract was for 3 months. And then here we are 20 years later. In that time, I've also worked for UNICEF for 6 years. I've worked for those two organizations, and I've worked in a few different places. I mean, WHO, central coordinating authority in global health. That's what it says in the WHO founding constitution. And that's essentially what it does, although, of course, there are many other different sorts of organizations. I think what distinguishes the World Health Organization is that central coordination function. the fact that it is an organization of the member states. People often think of those of us in the Secretariat working in buildings in Geneva or Cairo or Manila or the almost 150 countries where WHO has offices. But WHO is an organization of the world's people. Every member state, no matter how big or small, gets one vote at the World Health Assembly. There's no veto power, unlike other parts of the UN. And I think it's that relationship with countries, with governments, with people that distinguishes the World Health Organization. The World Health Organization is a specialized agency of the United Nations. Whilst we do provide funding, it's not primarily a funding body, but its job is to set standards, to provide norms, provide data, provide guidelines, provide guidance. But then we also have an operational role in emergencies. And my relatively small part of the World Health Organization where I work is called the Alliance for Health Policy and Systems Research, and we support health policy research, health systems research, implementation research in low and middle income countries. But we work with the rest of WHO so that research is a way to serve the WHO mission.
I spoke with Aaron Carroll from Academy Health, who focuses on US research primarily, but also with a global perspective. Very enlightening conversation. That's a podcast that we're going to publish very shortly. And I'd love to maybe compare and contrast his views versus your views on some of these critical topics. But I'm also just still in the context of framing your research versus, say, OECD research. Are you focused on different countries? Are you focused on the same countries, but different questions, different subjects? How do you compare yourself to that organization?
So certainly there are similarities between the OECD and WHO as a whole, and WHO and the OECD work together often. And we know many of the colleagues who work on health systems at the OECD. Of course, the OECD is an organization of the OECD countries. So it's an organization of the mostly high-income countries in the world. So that's one important difference. And so its focus is more on those countries, right? Whereas our focus at WHO is, certainly at the Alliance, is on low and middle income countries. So that's one difference. I think the second thing is often the OECD does analyses across countries, and WHO as a whole certainly does that. Our focus at the Alliance is very much in supporting people in low and middle income countries to do research themselves that meets their needs and address their problem. I think the other difference between the OECD and WHO as a whole, in WHO, in this building where I'm sitting in Geneva, you can find a global expert on any topic in public health. And I don't think the OECD would claim that is their role. They particularly focus on issues of the financing of healthcare, looking at quality, but they play a very important role. But it's a different and complementary role to that of the World Health Organization. And the research that they support is quite different to the types of research that we support at the Alliance.
Okay, my last framing question, and then we'll get into your areas of focus because they're so interesting. I can't wait, but I feel the obligation to frame. Talk to me about a Socratic forum of ideas and the freedom that you feel to express yourself, debate, disagree, argue within the WHO, share your thoughts publicly versus the balance of being a unified organization, because ultimately the WHO has one global leader who has to, and I asked this question with extreme empathy for how complicated healthcare is. I don't think there is a more complicated topic out there for us, right? Our own health and all the different variables that go into it. I would argue it's even more complicated than commerce. And so it's easy to be wrong. It's hard to be right. And so an organization that's filled with experts, I can only imagine, is wrestling with many different contrasting views on complicated topics all the time. How do you create the right amount of uniformity, but not too much uniformity so that you all feel censored? What is the balance?
Look, I've worked as a clinician. I've been a clinical doctor. I've worked in a Ministry of Health. I've worked managing health programs. I've been an activist. I've worked in a university, and I've worked at WHO and UNICEF. Personally, I would say that my own experience is that the intellectual freedom, the ability to contest ideas has been richer for me personally in this space than in any of those other settings. And that's one of the reasons I stayed, right? Is that I have met such wonderful colleagues throughout my career. I've been able to debate. I've learned so much. When I first joined WHO, I was a relatively young man. And that first year was such an education. So I personally have found it a very intellectually free space. Now, we are the servants of the world's countries and the world's people, and that's a very important duty. We are bound by a code of conduct as being international civil servants, and that means we have some responsibilities. That means that we are not free to express ourselves on some things as a normal citizen because we have this responsibility and it could undermine our work. But I have found within WHO and within UNICEF a very free space.
So there's a standard of decorum, but not
Right,
necessarily.
but I think the thing
Okay.
is that we also are very lucky to have trust. I mean, this year I have flown into, I think, 4 countries and met with ministers of health. And in fact, I was in Ghana last week and I met with the Minister of Health. And that is not, whatever I may think of my own merits, that is not because of me as an individual. That is because of the organization that I work for. And that is because of a 70 plus year history that the World Health Organization has with these countries. And that is what you're going to. So you have to respect that trust. The other thing, though, I will say is that our boss, Dr. Tedros, is I think, one of the bravest director generals that we've had. And he has very much spoken up often on challenge issues. You've heard him speak on Ukraine, you've heard him speak on Gaza. And I think that sets the pattern. Right. So, whilst we must respect our responsibilities, that doesn't mean we can't speak up on difficult things. And I think there have been other periods in the organization's history, I would say, where we have been more cautious. But I think in this moment, where there are so many crises and so many things under threat, I think as an organization led by Dr. Tedros, WHO is speaking up about challenging things. And I think the evidence is there. So in any job, you have to balance your corporate responsibility, the reputation of your organization with your own views. There's always a balance, especially when you're in a leadership position. But again, I would repeat that I personally find it a very intellectually free space. It's an organization whose values also reflect my own values. And I feel, talking with you here today, that I'm able to express myself.
That's very helpful. All right, Kumanan, we're diving in now. No more framing. All right. So you're the executive director of a research arm within the WHO. You've published reports on primary health, leading reports, and you've studied social determinants of health. You've worked in so many countries. You've been to and interacted with ministers of health in many more countries. You're the right person to ask. Imagine that you were staring at the planet and you weren't actually on the planet. You were just staring at the entire globe. And your lens, your glasses gave you the immediate ability to evaluate, compare care, health systems, health care across different continents. And you could even color code them based on excellent, okay, and really struggling. And even go a step further. You could create different colors for pockets of real growth and optimism. Areas within Africa that are flourishing, that are showing real buds, that will grow over time into excellent healthcare. What do you see? Give me the benefit of your eyes as you look at the world continent versus continent before we go into countries and before we talk about more granular subjects.
So I see a sort of paradoxical picture in the sense that on the one hand, over the last 25 years, which might be called a golden era of global health, and obviously that era is changing, there has been unprecedented progress in health and in health outcomes. In many countries as well, life expectancy has increased at a rate as fast as anywhere in human history. So countries like Cambodia, countries like Rwanda, countries like Ethiopia, at least before this decade, life expectancy has increased dramatically. The number of children that die every year under the age of 5 has decreased by more than, well, we have less than half the deaths under 5 every year than we did 20 years ago, despite having more births. Of course, far too many children still die, but there's been real progress. We've made real progress against diseases like HIV and malaria. And yet at the same time, we haven't made the progress that we should have. So I'm optimistic but impatient. 4.5 billion people still lack access to the health services that they need out of 8 billion. And since 2015, progress on many of our indicators has stagnated. And then the COVID-19 pandemic disrupted health systems all over the world, led to reverses in life expectancy in many countries for the first time in a generation. And we have a perennial challenge of inequality. And the type of inequality that we've seen has changed with the progress we've seen. So whilst 40 years ago, the grossest inequalities in health were between countries, we have made progress between countries, although there is still a long way to go. But we have increasing inequalities within countries. And that's at all income levels. Right. So it's that paradox. So we can deliver more and do more, and we've seen how the world can come together to address problems and make dramatic progress. And yet we're still not delivering so many of the things that we need to know how to do. And I'll give you an example. Penicillin was discovered in 1928. Penicillin was discovered or invented in 1968. And yet here we are, almost 60 years later, and over 650,000 children die a year from pneumonia. Most of those cases are preventable if we could diagnose at the right time and deliver a dose of amoxicillin that costs less than $1. At the same time, we're in this incredible age of discovery of new pharmaceutical therapies. We've new drugs for cancer, new drugs for autoimmune disease, for cardiovascular disease, for diabetes and obesity. So there's a huge, what we would call a no-do gap. There's a big gap between what we know how to do and what we actually do. And that's the field. That's the type of research that we at the Alliance focus on.
Also feels a little bipolar, right? On one end, we have tremendous access and incredible advances in healthcare. On the other extreme, we have children that don't even have access to the most basic drugs to prevent pneumonia. So that is extremely frustrating. That doesn't sound like a problem that we've yet solved. Fair to say?
No, I mean, we have made progress on pneumonia. I mean, that's why child deaths have decreased. That's one area we've made progress. But the progress is too slow. And part of the reason is that we still haven't been able to ensure health systems in all countries that can deliver the services that people need, regardless of your population group or where you live, right? And over the last 10 years, we have seen a slowing of progress in doing so.
Okay, so building on that point, as you look at this globe, which continents is the WHO, is Kumanan spending more time on than others? Where is the fire burning hottest? Which continents are you seeing tremendous progress? They're developing at a very decent rate. They're building their own systems. They're investing appropriately, building the right infrastructure to improve their own healthcare metrics year on year. Just walk me through the geography of it. Before we get into specific country hotbeds, just continent by continent, how's the Middle East compare to Africa? How does Africa compare to parts of Asia? How do parts of Asia compare to Central and South America? You have a very global perspective, so let's just start from there.
So in every continent, there are countries that have made dramatic progress, that are star pupils, that are doing innovative things that improve the health of their people.
Name a few of them for me.
So, I mean, I would say that, in terms of health systems, countries such as Thailand, the progress that China has made in recent decades, the progress that countries like Oman have made, Turkey, in Africa, countries such as Ethiopia, Rwanda. There are countries, as I said, in every continent. I mean, probably the most exciting health system in the world today is in Estonia. In terms of the use of digitalization, it's a laboratory for a new health system. So in every continent, there are countries that are doing amazing things. But what I will say where the challenges are, where I worry most about, I mean, we still do most of our work in Africa and in parts of Asia, particularly South Asia, which are the countries with the highest levels of mortality and where health systems we need to see the most progress, right? And that, again, to say there are incredible examples of innovation, of progress within those regions. But the other thing that brings together where, as you said, literally the fire is hottest, is that the people with the worst health in today's world live in context affected by conflict. That is the commonality. That's where the people have worst health, because health systems are disrupted, supply chains are disrupted. Beyond the direct traumas from war, there's also the sort of subacute impacts of war, disruptions to regular services, disruptions to nutrition, to the social fabric. 2 billion people now live in countries affected by conflict out of 8 billion. Last year, there were 61 conflicts in the world. That's the most since World War II. And if you look at progress, it's really in those contexts where we're seeing the biggest challenges. And even within countries, it's in the parts of those countries affected by conflict where we see the worst.
What would be examples of countries that most people don't think of when they think of conflict? So obviously Ukraine and Gaza grab 95% of the headlines. Maybe Sudan gets a little bit of attention occasionally. Parts of Nigeria, North versus South. But most people would think Central South America relatively peaceful. Most of Asia relatively peaceful. The Middle East, I wouldn't call peaceful. Whether it's Yemen or whether it's Syria, right? These are very hotbed locations, Lebanon. But what are some of the other locations that most people don't appreciate come with hundreds of millions of people and conflict, and yet don't grab any headlines?
Well, exactly. I mean, sadly, we claim that every life is of equal value, but the way the
That's
world
not the way our
works,
media industry is built.
the attention, one life is not of equal value. And that's a very sad thing. And that's why WHO works across the world, in all the countries of the world, trying to keep true to that sort of a maxim that every life is of equal value. So you mentioned Nigeria, but there are a whole range of conflicts in West Africa that we don't hear so much about often outside of the region. Countries like Burkina Faso, countries like Mali, we don't hear so much about those conflicts. Even the challenges in northern Nigeria are not uppermost. The very, very challenging situation in Sudan. I mean, how much do we really hear about that? We've heard a bit more recently. That's an absolutely devastating situation affecting millions of people. And WHO is in all of those places. But then if to move to other contexts, in South America, what has happened in Venezuela over recent years, the millions of refugees, regression in progress around maternal and child mortality. I mean, in a very, very challenging situation. There are different types of conflict. What happens in Haiti, right, which isn't necessarily a sort of formal actor conflict, but tremendous insecurity, tremendous undermining of health services. Even in Asia, there are a number of conflicts. Myanmar, I mean, the devastating situation. How much do we hear or talk about Myanmar? So I think my point about that statistic about 2 billion people, I mean, in every part of the world, there are conflicts. And as I said, that this is where we see the worst health.
You make a wonderful point, and you're helping me understand a critical point. Every country needs to build 2 healthcare systems, and most haven't built one. But when you really frame it, you need a system for the people that you think you have, and then you need another system for the people who are arriving. And it's that movement of people in and out of danger, which creates its own set of healthcare demands, right? 20 million new migrants into the US, some legal, some not. It doesn't matter. There are 20 million people in the US have healthcare needs. And the infrastructure required to provide them with basic care is a need, right? They're here. And every country across the world faces that challenge at different stages. And conflict is nothing generates movement of people more rapidly and more hazardly, chaotically than conflict. So it is really interesting to think about from a mechanical standpoint. It's not enough to say, I'm Sweden, I have 30 million people, I'm taking care of all of them, I'm good. Because all of a sudden, there's 2 million asylum seekers, there's 2 million refugees, and they're there too, and they also have needs. So it's ever changing and very demanding. Let's get into the structure of it. So you look at the world, you look at these countries, and you have 2 or 3, maybe 4 or 5 tasks of each country that you think if they make good on, you could sleep relatively well at night knowing that they're building the right health system for their residents, all of them, whether it's the right investment in primary care, which I know is a really core subject for you, not just relying on hospitals to take care of everything, but understanding that the inbound, the top of the funnel component, the continuous care requirement, the coordination of care, and all these things are critical too. And hospitals will never excel in those areas. It's not their mission, right? Or whether it's the balance between government paid, single payer, and private pay. Is it 50-50? Is it 100-0? Is it 90-10? That ratio, I imagine, is very interesting to you. The per capita metrics that are most important to you, number of physicians per capita or per 1,000 citizens or residents, how many clinicians are out there? A big subject for me here in the US is our residency program. I'm going to start to spend more time unpacking it because it's completely broken. And we're not spending enough time asking that question. Why is it that 40 years later, we still have the same 1980s methodology and policy regarding the number of residencies that are allowed in this country? So walk me through your list of 3, 4, 5 key determinants of whether or not a country is going about healthcare the right way versus room for improvement.
So, Roy, perhaps we can start by looking at what one of the most celebrated health systems in the world, the National Health Service in the United Kingdom, which you probably know a little bit about. And clearly it's had a lot of challenges in recent years, but they just released their 10-year strategy in July, and it said they wanted to do 3 shifts. And the shifts were to go from hospital to community, to go from sickness to prevention, and to go from analog to digital. Doesn't sound like groundbreaking stuff, but on those 3 shifts are some of the basic challenges that every health system is struggling with, right? So let's go through them, because it is really about the principles of primary health care that were laid out in 1978. And I would argue that those principles, that health is a right, healthcare is a right, that there's a right to health and there's a right.
What happened in 1978?
So 1978, the countries of the world got together. There was a WHO UNICEF conference in what was then called Alma, now Almaty in modern-day Kazakhstan, then part of the USSR. But all the countries of the world. Ted Kennedy went to represent the United States. And they agreed that primary health care was the strategy towards health for all. It was inspired by experiences from around the world where in post-independent countries, what had been seen is that often the countries had what followed the sort of Western model, had built big hospitals in the cities, but most people who lived in rural areas just had no access to healthcare. But that communities began to
All that suitcase healthcare. You pack your suitcase to go get treatment because they're going to be sleeping at the hospital, whether they want you there or not, probably in the waiting room.
Yeah. So there were these community innovations, experiments of how to deliver healthcare. And this led to the Declaration of Alma-Ata, which said the way to achieve health for all was through primary healthcare, which meant affirming health and healthcare as a right. I know, controversial in some circles, saying that health care should be delivered in an affordable and an appropriate way, as close to where people live as possible, delivering the set of services from preventive to curative, and that where those services couldn't be delivered there, then coordinated to higher levels of care. That health couldn't only be achieved through health care, it required action across sectors, and that people needed to be involved in decision making around their own health, but also around the way health services were arranged and delivered. And I would say that those principles, even in a world with AI, are more relevant than ever. I will have to say that because in 2008, we wrote a report, WHO World Health Report, primary healthcare now more than ever. I would say in 2025, almost 20 years later, primary healthcare even more now than ever. And yet that has been a challenge. And so if countries, and the point is there's no sort of single bullet formula of how to deliver appropriate healthcare for your people. If you look at a graph of the GDP per capita against life expectancy, you see more variations within the bands of life expectancy often than you see variations across GDP levels. Now, obviously, up to about $10,000 GDP per capita, life expectancy increases very dramatically. You absolutely do need a certain amount of money in your country to deliver basic healthcare. But after that, the variations are about policy choices. So income is not destiny. And so countries that are able to develop systems, whoever is providing it, which reaches all of their people, that are able to provide most of the services that people need in an affordable way, thinking about what sort of cater to use, are able to work across sectors on what we would call the social determinants to support health, and where people are engaged in healthcare, trust healthcare, have input into decision making, do better.
What would be an example? Are you going back to the UK?
Well, I mean, it's, again, in our circles, it's almost cliche. But if you look at what Thailand has been able to do over 30 years to achieve essentially universal health coverage, what they have done is that they have all of those principles. They've really prioritized primary care. They've ensured that doctors go to across the country. They arrange that through a range of incentives and regulation. They have very strong links to communities and community health workers. They've ensured supply chains. They've adopted technology. They have thought about financing in a sensible way, and they've continued to make progress. And they've done all of this in a context where the politics is not stable, if you know Thailand. So sometimes people say, oh, you can only do this if you have political will. But there's been a collaboration between all parts of society, champions, some of whom are in the government, some of whom are in academia, some of whom are in civil society. They're actively engaged with the private sector. They have something called the Thai National Health Assembly. And yes, they've also had economic growth, but they've been able to essentially to deliver universal health coverage for their people. So that's an example, and that didn't happen overnight. It happened over a 30-year period, constantly pushing 2 steps forward, 1 step back, right? So I think those principles of this, and they've really thought about prevention. They've funded through earmark funding health promotion activities. So that point about going from hospital to community and from sickness to prevention that the NHS has identified, we've been trying to do that for a very long time. The new opportunity that the NHS strategy highlights is from analog to digital, and that's very exciting. And I'm sure you've talked to a million people on your podcast who are excited about the potential of digitalization and artificial intelligence. And I think that is very exciting, but it needs to be stewarded in a way that delivers for people, that it's not just about the gadgets and the widgets. And again, I think that those principles of primary healthcare that I articulated are more relevant than ever for an AI-enabled health system.
I'm going to be a little bit controversial here and stimulate a debate.
Please.
The question that comes to mind for Thailand is the same question that comes to mind for the UK and for every country that has committed to the universal coverage single payer program, which on paper sounds awfully attractive, right? It's going to be a lot more coordinated than multiple payers, right? All the data in one, all of my patients I'm responsible for, absolute negotiating leverage on suppliers, whether they're medical device or drug suppliers, whether they're providers or ultimately suppliers of care as well, top down to the extreme, singular. It sounds amazing. The challenge that every one of these systems seems to run into, including Thailand, is less money. These governments, and I want to applaud Thailand, they've done an amazing job. They have lifted themselves up from very weak, preventable mortality to access to basic care. And I'm sure they've seen tremendous improvements in life expectancy and quality of life as a result. But, right, it's not enough, not in healthcare. People want more. They want the very best of everything. And I don't know of a country that has adopted a single payer program, government funded. The NHS is a great example and very near and dear to my heart, who's been able to keep up with the additional progress that private alternatives facilitate, right? Best in class specialty care, chronic care, continuous care, digital care. It doesn't mean that these single payer systems don't try to, and it doesn't mean they don't need to continue to try to improve. They do. But the NHS is on an annual basis going through some kind of desperate revolution to try to fix itself. This is every year it tries to fix itself. Now, that's an unfair critique because, frankly, every country is full of criticism towards its own healthcare. for different reasons. Even in Sweden, my understanding is a lot of Swedish residents would like Swedish doctors to be a little bit more performance orientated. And Norway too. And Norway has all the money in the world, right? It's a very blessed country in terms of resources. Very small population, unbelievable amount of resources. So that's my question to you. Do you really think that a full reliance on tax revenues gets the job done, given how much needs to be built? And when you really get to excellent care, don't you need an enormous amount of money spent on innovation within your own country too, let alone emergency supplies in case the world goes to panic as it did in 2020? What are your thoughts?
Well, there's a lot in there, Roy, and a lot of questions. But I would answer what I think is your main question in three ways,
Yeah.
right?
Private-public partnership versus public-public.
Firstly, without using significant tax funding and public stewardship, if you look at the countries that do well, people are always dissatisfied with their health system. It's a challenge. But if you look at the countries that
Nobody
get
wants
better
to
outcome, that are more efficient, that are more equitable, they generally have a large amount of tax funding. And so, the US, for example, I mean, Medicare and Medicaid, I mean, that's the largest publicly financed healthcare program in the world, right? Even though in the US, people don't think of it as
I think we've hit $2 trillion of government funded.
So my point is that if you're trying to get an equitable system and you're also trying to do it in a relatively affordable way, it's hard to avoid having a significant government role. I think that's the first point.
100%.
And the second point is that firstly, we're talking about that where children are dying of pneumonia because they don't get amoxicillin, you're really trying to raise a system that is able to deliver a set of services that will dramatically improve life expectancy, that will improve people's lives, allow them to do other things, allow there to be economic growth, right? And so really that's what we focus on. I mean, those are the countries that we're focusing on, right? But I'd say the third one, I would say, I agree with you that we are in systems that do those relatively well. We see a lot of crises because we see aging populations, higher patient expectations, costlier healthcare, changes in the health workforce, a lot of dissatisfaction, and a real challenge with all of these new technologies, increasing the costs of end-of-life care, of social care. So there's a lot of stresses on it, right? But what I would say for those
tax revenues, and yet
for those countries, I think what we're looking at, and we discussed this in Berlin, is that probably finally the whole model of a health system is going to have to dramatically change in the next 10 years. And that's in those more established systems to address many of these challenges. But also, there's the chance in systems that aren't as advanced to use some of these innovations. They don't have to go the same path that all the other countries did. They can see what the UK is, and sure, even Thailand has an aged population, the challenges they're having despite their progress, and they can anticipate that and do things differently. And I think that with innovations in the technology that we're seeing, there's great possibilities for that. On the public-private, I think the point at the end is not who is delivering the care. The point is that you do need to steward your system, and the government does need to do that, and that you need to pool the money you spend. If the money is all being spent by individual people out of their own pocket, that is inequitable and it's inefficient, right? And there's traditionally been the so-called beverage system, the UK tax-based system. There's the Bismarck, the German health insurance system. So you can have public and private providers. I mean, and what you are, as you say, in many of these countries, whether it's Thailand or the UK, wealthier people often go to private providers for some of the technologies. And of itself, whether it's a public or a private provider, I don't think is the main point. I mean, some people do. Some people are very strong, must be all public. Some people are like, no, the private sector is the fountain of innovation. For me, I'm practical. I think you have to work up a mix that works, but none of it will work in any system unless you have the regulation and stewardship capacity. And that is something that governments need to provide.
I pretty much agree with that word for word. My bias towards a private-public partnership is more born of they say market, but it's not really market. It's a diversified approach to building and finding solutions for complicated problems, as opposed to a singular approach. A diversification, again, not the word market, but a diversification in sources of funding. I'd rather have 5 sources of funding than 1 in life in general. I think 5 outperforms 1. So that's really where it comes from. But I think your larger point of coordination It's not necessarily the uniformity in funding, which you say is not that important. It's the uniformity in analysis and in influence that really is critical, because you have all these disparate patients and all these disparate providers and all this disparate data. And who's going to organize for all of that in order to provide guidance on what's working, what's not working? You can't just leave it to 1,000 different actors pulling in 1,000 different directions. We're not buying shoes here. The invisible hand concept is helpful, but it's not necessarily final or absolutely determinant when you're dealing with a very complex industry. And I think that's a nuance that we really need to highlight and emphasize. You can't rely on free market principles to get you through everything in life, right? The whole concept of public sector and the role that it really needs to play. So I think it's really good feedback from you, and I really appreciate it. I wanna jump back to Estonia. You said Estonia, right?
Yes, I did.
No one's ever mentioned Estonia to me before, and I'm fascinated. Talk to me about it. You speak of it as a wonderful case study in all kinds of interesting ways, like digital care. What's going on in Estonia?
I think, again, that question about the public and private, and then the coordination and the data issue, I actually think that we're in a very interesting time where we might see some new solutions for that. And I think they're starting to play out. I think the challenge with the public and the private is around the alignment of incentives, because in the end, the private sector operators have a clear metric in terms of return on investment, right? I'm not saying that's the only motivation, but that is the primary and what is measured. And so what we tend to see in mixed systems is that the private sector is quite good at finding the patient populations that are most profitable, right? The easiest to access. And often in those mixed systems, then the public sector is bearing the responsibility for those populations who are harder to treat, who often for some of the more expensive services. And so there's an equity issue and an efficiency issue. So for example, in a lot of mixed systems, you'll see private providers who do high volume, profitable procedures, for example. But when things go wrong, they offload patients onto intensive care units in public settings, which are very expensive. So there's not a shared investment in the cost of the system. Often training in mixed systems, the cost of training is borne by the public system. So this concept of cream skimming, right? So absolutely, you need to mobilize all the assets you have in society. But if you want to do that equitably, a private dominant system generally doesn't deliver that, right? And then also this question of who is investing in the system and who is profiting, right? And I think that if you want to have genuine partnership between the private and public sector, you have to have some very honest conversations about those issues. And I will say that I really see those conversations, and they're very challenging.
You rarely see them.
Rarely see them, indeed, right? So I think that, but then I would say
you're having one of those conversations right now.
Yeah. But I would say that I'm very excited about digitalization and artificial intelligence. So Estonia is a country, which is a small country. It was a post-Soviet state. They had a Soviet-style health system. And then after they got their independence in the fall of the Soviet Union, they really led the world in digital citizenship, right? And that is reforming, revolutionizing the relationship between the citizen and the state. And you also talked about non-citizens. And I think that's something else to consider. And I think in the health sector, we're often behind. Other sectors have moved forward on digital citizenship. As I mentioned when we were in Berlin, most aspects of my life have completely been transformed since I was a child. But going and accessing healthcare hasn't. I mean, I'm living here in Switzerland, a very wealthy, very strong health system, but I still struggle to find an appointment. Then I get the appointment, I go and wait. Often I have to wait a long period of time. Then I go and see someone in a facility behind a desk. Then they might refer me to other things. But that we have more technology, but the basic model hasn't changed in a way that it's changed for banking, or that it's changed for the way we deliver messages, or the post office, or the way we take photos. But I think that change is going to happen in the next 10 years, because finally, artificial intelligence and digitalization is going to deliver on the potential of that, which hasn't really fundamentally changed in the last 30 years. So in Estonia now, people have their health records on their phone, and they can grant people access to providers. Right? So that changes the coordination discussion. Instead of it being, is the state coordinating between all these providers, or is the public sector talking to the private sector? you can go to whichever provider and they can have your data. Now, that relies on digital public infrastructure. My colleague, Alma, who leads the digital health team here at WHO, that's what he works on. He's very passionate about it. It relies on that pipe to allow data to flow. But this is back to the principles of primary healthcare. Let people decide how their care is delivered, have input into it, have control, rather than just being subject and hoping that the public system or the private system are coordinating. And so I think that obviously it's a relatively small country. I mean, we're seeing very interesting things in countries like Singapore, Rwanda. Obviously, in those countries, they're very different income levels. Singapore's by far the wealthiest. It's easier to innovate at scale in a small country. But if you look at what's happening in China, similarly, we had a colleague last week who was presenting on essentially China has a vision that every person will have an individual AI agent for their healthcare. They've already started opening AI hospitals. China is very much focusing on integrating AI, whatever model they have, into everyday useful things, right? Rather than necessarily waiting for artificial generalized intelligence. So I really do think that some of the dramatic disruptions we've seen in other sectors over the last 30 or 40 years, we're going to see in the health sector over the next 10 years. And that will mean many of the questions that we've discussed today we'll have to think about very differently.
I think that's fascinating. I will leave you with this thought as you leave me with that thought, that the size of the US private sector in healthcare is $3 trillion, all private. The government piece is 2. So we see it all. We see the cream, that cream concept of I win, you lose, I win. No matter what, I'm benefiting and you're not, it is real. The limitations of for-profit incentive are real. And we see broken pockets of arbitrage that are exploitative, in many cases unintentional, in some cases intentional, risk profiling as part of accountable care to benefit me in disproportionate ways, abnormal profits for very little risk taken. We see that in healthcare. Healthcare is hard to get right and policies don't always work as intended. We're going through that right now with ACA and Obamacare and the subsidies that have been offered to these insurance companies. But we also see so much more here in the US where the private sector in healthcare has been allowed to demonstrate what it can do fully, right? Not in other countries where the private sector is 5% of provided care and is still fledgling and confused and, wrestling with, cash-based payment programs, no insurance, a little bit of aesthetics, right? A little bit of high street derm or dental, and that's about it. It doesn't really tell you much about what a private sector in healthcare can be as a partner to the public sector. So beyond the cream, we see a lot of risk taken, right? Which in many cases leads to failure, right? A lot of bankruptcy, a lot of personal hardship. I tried to build a large primary care business and instead I lost money for 10 years and became very poor doing it, but I tried. We see a lot of solutions, a lot of success that is measured beyond profit, but is measured in things like innovation and access to care and elevated quality, innovation in delivering care, in measuring care. I would say this to you, Kumanan, there's no single thing that we do in our society, nothing in any industry that doesn't come with a public-private partnership. Even if you look at defense, or even if you look at a police force, a pure social good, social product, there's no private police force. There's private protection, there's security guards, but there's no really private police force anywhere. Those police still outsource and delegate their equipment, the manufacture of their equipment to the private sector, from their cars to their guns to their belts to their badges. They still delegate huge parts of what they do every day, their communications, the consulting that they need in order to improve their performance, the measurements of their performance. There's so much, even within the police force, that is a public-private partnership. The rub is always what's working, what's not working. But that would be my pushback to you is I think the concerns are real and they should always be there, because I view it as 2 siblings living in the same house. They're not the same person. Public sibling versus private sibling. They have different attributes, different virtues. They have different limitations and different behavioral issues, but can they get along? Because they both live in the same house.
Thanks so much, Roy. What I would say is exactly that. It's not about labels. It's about what does the health system deliver. In the end, a health system needs to deliver improved health outcomes. People need to trust it. They need to value it, and it needs to meet needs, and it needs to be able to change meet changing needs. That's actually a framework for a commission led by Margaret Crook. And I think it pretty well sums it up. What I would say, though, is that what we haven't done well is steward all our resources. A system or a state that's only public sector, that doesn't have a private sector, is a totalitarian state, right? So, of course, all systems are mixed. You cannot have a wholly public system. No system is wholly public. And so the question is, who is going to steward to ensure you have the optimum contributions? I mean, the US is a very interesting example because on the one hand, as you say, you have incredible healthcare, incredible innovations, and yet life expectancy in the United States has regressed over the last decade. You cannot say a health system is doing well if people are getting sicker, right?
But I'm one of the few who says that.
Well-
But that is a different podcast. We'll get to that.
So we'll leave it with that. That certainly would be another debate. And thank you so much. I really appreciated being with you.
US healthcare, you'll always hear me say it's so much work to be done, but that life expectancy gauge is highly misleading for us. But that is a different podcast. We'll get to it. Kumanan, I really appreciate your time. Thank you, my friend.
Thank you, Roy.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.